So Dr. Silverman is a pediatric psychologist and professor of pediatrics at the Medical College of Wisconsin. He obtained his bachelor's degree in psychology at the Ohio State University in Columbus, Ohio, and obtained his PhD in psychology at the University of Wisconsin-Milwaukee. Dr. Silverman then completed a postdoctoral fellowship in pediatric psychology at the University of Michigan Health System at the C.S. Mott Children's Hospital in Ann Arbor, Michigan. Currently, Dr. Silverman's primary clinical services are provided through the section of gastroenterology, hepatology, and nutrition, working with families of children diagnosed with feeding and nutrition disorders, and with families of children diagnosed with elimination disorders. Dr. Silverman co-directs the interdisciplinary research efforts of these programs at Children's Wisconsin in Milwaukee, emphasizing studies of disease etiology, treatment efficacy, and technology-based interventions. He is an internationally known researcher and lecturer with numerous grants and over 40 original publications. One of his greatest joys is training the next generation of researchers and clinicians. Thank you. For the last 15 years, he has had the pleasure of serving as the clinical training director of the Children's Wisconsin Psychology Training Program, which has trained over 100 graduate students. Thank you for being here, Dr. Silverman. Please join me in a warm welcome. I'm sorry you cannot hear all the applause. If you can get your applause icon up, that'd be fantastic.
The reality of Zoom, right?
I know, right? Well, take it away, Dr. Silverman.
All right. I am so grateful for the invitation, and I'm really pleased to be here. I really do enjoy the teaching element of things, and anybody who will give me a microphone, I appreciate that. So thanks for having me. Let me pull up my slides. All right. Hopefully you can see them okay. Great. I will go ahead and get started then. I'm going to be talking about that subject that everyone's a little reluctant to talk about, especially over the lunch hour, which is the diagnosis and management of toileting disorders. Disclosures, I wish I had some to offer, but if anyone has any grants that they would like to offer me on this particular area, I would gladly accept them. But nothing to report other than my salary related to this particular topic. The learning objectives, I believe, have been given to you ahead of this talk, but basically my hope is that we can make this conversation a little bit easier and that it's easy to understand the different subtypes of these toileting disorders, that you can understand the roles of the medical and the behavioral providers in identification and doing the diagnostics, and in understanding the methodologies that one might employ to treat these conditions. So, toileting disorders are one of the most challenging things that I think young parents are dealing with at any particular time. And the reason for this is that it's an essential adaptive daily living skill. If you can't toilet, you can't go to school, you really don't get invited places, and it's a cause of a lot of frustration and shame for parents, and a cause for a lot of frustration and shame for kids. So this feels like, and is, very high stakes for most children. The rates of fecal incontinence are surprisingly high because most folks feel like I'm the only family that's dealing with this because it's that dirty little secret that nobody talks about. But essentially it's 3 to 5% of kids, which means in a standard classroom, that's one kid in every classroom. Urinary continence rates are much higher than that, even 15 to 20% of children. And even though these concerns are quite common, unfortunately, it takes a lot for families to feel like they can talk about it, even with their pediatrician. So let's begin with the stooling disorders. Stooling disorders, also known as encopresis in the psychology literature, or fecal incontinence in more of the medical literature, are generally characterized by chronic constipation, fecal impaction, leakage of stool, and overflow incontinence. Retention is believed to be the root cause of most of this, which leads to painful stooling events and withholding behavior that perpetuates those symptoms. And as I said, about 3% of school-age children are estimated to have encopresis. What you may not know is that it affects boys at a much higher rate than it as girls at about a 6-to-1 ratio. And the thinking on this is, of course, that the anatomy is different, but I would put forth another theory is that the way that boys toilet is different than the ways that girls toilet, especially moving into school, because boys no longer sit down to urinate. And I think the opportunities for defecation become a little more limited and withholding becomes more pronounced in boys. That's my own personal theory. There's not been any studies to really discern why boys have it more than girls do. So I don't know when the last time you guys took a good look at the GI system was. I'm guessing it's probably a while ago. So why don't we jump in? This is something that I do for all of my families because I think you have to have a basic understanding of the anatomy before you can get into how do we manage it. So here, what I have is a diagram. Hopefully you can see my arrow here. This is the esophagus leading to the stomach, where any swallowed food is liquefied by stomach acid and by the propulsion of the stomach muscles. Gradually, materials are exited into the small intestine, which absorbs nutrients into the bloodstream. And it's a very efficient system because the small intestine, by definition, isn't so small. If you stretch it out, it's about the size of a telephone pole. And it's a very narrow tube that's filled with millions of cellular walls that extract that nutrition. So it's a very effective system. By the time the material dumps into the large intestine, what you have left is waste and water. And the job of the large intestine is to concentrate that waste by absorbing the water back into the body's bloodstream. And by the time that you get to the rectum, hopefully what you have is a soft, well-formed stool that's ready for delivery from the poop factory, as we would say it in my clinic. Can't start the morning without your coffee, right? So here's your Bristol stool scale, which should help you know, is a textured stool appropriate or not? Generally, when stools are too loose, you're gonna see these type 6 and type 7 stools that are watery or raggedy stools. When stools are too hard, you're really looking at types 1 and 2, where it might look like rabbit pellets or compressed little balls of stool. Typically, we would consider types 4 or 3 through 5 to be more typical, with the Goldilocks poop being type 4. So when we're in clinic and I'm talking with my GI friends, that's the standard we're going for. Stool evacuation seems very automatic to most of us because it's something that we do every day, but this is actually one of the most complex muscle movements that we do. It involves involuntary muscle. It involves voluntary abdominal compression. You have to be able to relax the pelvic floor, and you have to be able to detect the urge to go when you have a full rectum. So when things are working well, we can relax that pelvic floor, give a downward push with our abdomen, and release the stool. When things are not going well, we may have a poor coordination of the movement, or we may even have withholding behaviors that cause the stool to become stuck in the rectum. And over time, what happens is that stool grows in size, and it grows in hardness, resulting in a condition known as megacolon. When kids have this condition, what you'll see is that the rectum stretches like a balloon to its greatest capacity. And when it does that, a child can no longer feel the urge to go when they have an appropriate sized bowel movement. And this results in not only soiling accidents, but a lack of effort to even produce a bowel movement until the stool is much too large. And then that results in painful, difficult bowel movements, which may even result in small tears in and around the rectum or the perianal area, which of course is quite traumatic to children. And when you're a child, you live in the moment. So if you're afraid your poop is gonna hurt, you're gonna withhold it, and we get into a bad cycle. So the diagnostic criteria I'm gonna go through first, these are from the DSM. Repeated passage of stool into an inappropriate place, whether it's voluntary or unintentional. There needs to be at least a full month, or I'm sorry, at least one event a month for up to 3 months or longer. In my experience, most kids will be having soiling multiple times a week, so that's a pretty easy diagnostic criteria to check. Chronologically, the child should be at least 4 years of age or equivalent in terms of their developmental age. So there can be a role for not diagnosing encopresis in children over the age of 4 if developmentally they are not 4 years of age. And this behavior really shouldn't be due to the effects of substances such as laxatives or a medical condition other than constipation. There are different subtypes of encopresis, 2 that I want to focus on specifically. The first is constipation with overflow incontinence. And this is when children will have that very large stool that is in the rectum that stretches the rectum. And the more newly formed stool that might be more liquidy tends to move around the stool mass. And because the muscles are stretched and because of the lack of awareness of a full bowel, that liquid stool may flow right out of the rectum and the child may not even be aware of it. And this is usually where I get the question from parents, well, how could you not know that you had a bowel movement? And this is where I encourage people to think about habituation. And a good example that I would use is if you like to cook, let's say you go into the kitchen and you're chopping up some onions to throw in the pan. Maybe when you're cutting them the first time, you notice that odor, but after they've been in the pan for 10 minutes, do you smell onions anymore? Of course not, right? And what happens if somebody else walks into the room for the first time? They notice the odor right away. So that's habituation, right? This is our brain's way of controlling for too much stimulus at a certain time. And this is a really good explanation. Another example might be, well, how can you not feel stool on your skin? Well, when you get dressed in the morning, you might feel your clothing go on, right? But do you notice the sensation of your clothes on you after you've been dressed? No. So, you know, this might be helpful to give parents the idea about why they don't detect these things. And of course, you have to explain the phenomenon of the overfull bladder, or I'm sorry, in this case, the overfull bowel as being a way that children cannot detect the urgency for stool because there's actual muscle and nerve involvement that diminishes their ability to know they need to go. The second type is actually much less common, which is encopresis without constipation and without overflow incontinence. So broadly, this category falls into 2 groups. This might be kids who have been seeking out medical treatment and they have good medications on board, so they no longer have a full bowel all the time, but they may have lost the ability to actually feel the need to go. And so they may have unintended incontinence. Whereas the other group, which I find to be much more rare, this is probably 5% of my caseload, are kids who have more oppositional behaviors and they use toileting as a way to express their oppositional behavior. I don't expect you to read this, but I bring this slide up to make an important point. These are the organic causes of constipation and soiling in children. And if you can read that very top line, what it says here is that organic causes are rare in children. So it's easy to get lost in this medical milieu of all these problems, but I'll tell you, if you really want to make it easy to understand why a children might be experiencing constipation or soiling, I would check first on their dietary habits and their medications that they take. Those tend to be, from the organic side, the most frequent causes. The other thing that you should probably know is that constipation tends to run in families. So if you get a history that an adult caregiver, parent specifically, biological parent, has these problems, then that might be an indication that there's more of an organic reason for the constipation. The medical evaluation usually goes like this. There's a referral to a pediatrician, and the pediatrician will say, well, okay, tell me a little bit about the stooling habit. They may prescribe some type of a laxative. Usually it's Miralax, which is a stool softener. And if things don't get better, then they may make a referral to a GI clinic. At the GI clinic, they'll again go through a symptom-based review with the caregivers. They may do some additional medical evaluation, which might include a KUB x-ray, which is, I'll show you a picture of one in a moment, but it's a x-ray of the abdomen that includes the kidneys, the ureter, and the bowel. And they may do other motility types of testing, such as a SITS marker test, which is a series of x-rays of little ringlets that come in a capsule and move through your digestive system. They can take little quick snapshots of these as they're moving and determine whether somebody has a true dysmotility, meaning the smooth muscle of the large intestine is not working. Another motility test that they may do is a test called a rectal mammometry, which is essentially a balloon on a catheter that is inserted into the rectum and inflated to simulate a stool in the rectum. And the child is asked to tell when they can feel that pressure. And there are norms that are based on that type of test. The other thing that they'll do is they'll ask the child to attempt to push the balloon out as though they were having a bowel movement. And then from that test, they can determine whether or not the child has the ability to coordinate a push to evacuate the bowel. Now, of course, the mammometry test is fairly invasive. So I would say you really need to know, is that test going to be of value before you go ahead and do it? Because many children have a hard time with that particular test. One other thing I'll comment on the rectal mammometry test before going to the next slide is that there are some providers who will use the mammometry equipment as a way of doing biofeedback. And they will have sessions where they can train a child who has poor coordination to learn to coordinate the muscle movements to push the stool out using that same principle of filling the balloon and then asking the child to sense it and bear down to push on it. So this is that KUB x-ray I was talking about before. And in the circle here, what you're seeing is a stool mass that's about the size of a softball. And this is a child who's about 6 years old. So for those of you that may be familiar with the anatomy, these are the hip bones. Here are the lower lumbar. Here's the child's waist right here. And so that stool is almost as wide as that child's waist. And you can imagine how traumatic that is. So the medical management is typically designed to help the child empty the colon and regularly empty the colon. So an important thing to keep in mind here is that most people will have a complete emptying of the rectum anywhere from twice in a day to once every other day. Outside of that, we would consider abnormal. So more frequent stools or less frequent stools than that should be a good red flag. Once you get a child's bowel empty, then we're really into relapse management. And that's generally done with medications to soften the stool and to help the stools to pass. So usually there's some combination of stool softeners such as Miralax in combination with a stool stimulant, which is usually the chocolate Senna, or better known as the chocolate X-Lax. Then I usually get the Goldilocks question, or I'm sorry, the crystal ball question, which is, how long is this going to take, doc? And it's a really hard question to answer because it varies widely from child to child. And it varies also according to relapse. So if a child goes longer than 3 days without a bowel movement, what happens is the rectum restretches and you essentially go back to day one of healing. If you can keep a child cleaned out for a full 6 to 12 months, most kids will have a full recovery. But now you have to really begin thinking about encopresis as being a chronic condition, because just getting them cleaned out isn't enough. And so now you have to start thinking about adherence to medication regimen, acceptability of that regimen by the family, strategies to make sure that families don't run out of their medications, even if they're giving them the way they're supposed to. There can be other conditions in the environment, economic conditions that may prevent them from getting their medicines. which are all big roles for extra support either by the medical community or by the mental health community. So if you do all of this, after about 6 to 12 months, most kids are better. The one thing I can tell you that may be a predictor is the longevity of the symptoms, and the severity of the symptoms may predict how long that recovery time will take. The good news is with medical management alone, about 60 to 80% of kids get better. So they don't necessarily need to come and see a mental health provider, and it makes it a good first stop because there aren't a whole lot of folks like me who do this type of work. And if they can get better with just the medical management, that saves the family time and precious resources of seeing extra providers. I think the rub, though, on this one is that most families, by the time they find their way to someone like me, have been in the system for about 3 years, because they typically start with their pediatrician, and then they get seen by a GI specialist, and then the GI specialist will work with the family for a while. And if they're aware of a mental health resource, then they may make that referral. But many GI providers don't even have a psychologist to work with. So that can be a problem as well. So the components of the medical management generally begin with an education phase where you're taught about the anatomy of constipation, how that changes the physical structures, the time that's needed, and the medications that are needed to really get the bowel empty and cleaned out and remain cleaned out for that period of 6 to 12 months to make things better for that child, to the point where they could and should be able to toilet independently. So according to the Academy of Pediatrics, a number of years ago, they put out a paper where they were talking about rectal management and what was considered to be efficacious at the time and what wasn't. So this paper was from 2006, but unfortunately they've not done an updated version of this paper. And the reason I bring this up is to give you a sense of how the physicians think about this. So again, I don't expect you to read this. But most of this is different types of medical evaluations. And then you've got this tiny little box here that talks about the behavioral modifications or psychological evaluation. This is starting to change a little bit. And we're starting to get some better data that talk about interdisciplinary management for these kids and showing the treatment benefit. But to be honest, the onus is still on mental health to get that data out there and to educate our medical partners in the role that psychology and other mental health or community specialists can provide. Another important thing that sometimes gets missed by the medical community are the effects that constipation and fecal incontinence have on families. So this is a paper that we put out a while ago that was sort of an exploratory paper. We did a qualitative study interviewing 50 families. And I bring this up just to kind of give you a sample of what we're hearing when kids come to us and parents come to us. And the general feeling from parents is that in the beginning, they're really angry and frustrated with their child. And then when they learn that this is a medical problem, they have tremendous guilt. And so it's nice when we can play the role to say, nobody really understands this all that well, including your pediatrician. And I wish that pediatricians got extra training on this, but frankly, they have so many other things that they have to learn. This one often gets only a short amount of time in medical school. The other component here in thinking about the adjustments to the condition prior to getting appropriate help is this notion that kids are constantly trying to control and hide from the symptom. So this is what drives the withholding. This is what drives the hiding of the evidence of soiling. This is what drives kids to avoid their peers when they get a little bit older because they get teased. And then I also wanted to share this with you. Before families get really good integrated care, they often try all kinds of crazy things to help their kids get better. And I love this first quote from a parent, which was the parent saying, that what they were doing they thought was helping. I can remember the last time you went a day without an accident. What was that reward? And then the child chimes in almost as if on cue. You never gave me a reward. You did not do that. And then the parent, of course, responds, don't you point your finger at me. And you can see how sensitive a topic this is. You know, if they're just talking about a reward system and it gets heated that quickly, you can imagine how the stakes feel within the family. So now I want to shift over to thinking a little bit about the psychological etiologies here. Typically, I've mentioned this already, there's a constipation history. So kids begin to predict the experience of a painful defecation, and they have a lot of fear about going to the bathroom. And this doesn't take a lot of negative experiences to draw this kind of a response, especially in our younger kids. A good analogy is, how many times do you have to touch a hot stove before you learn not to touch the stove again? Probably once, right? So if you have a large painful stool, kids can learn to withhold after just one negative experience. The other thing that they learn pretty early on is that if they can't control their bowel or their bladder, there's a lot of shame that they have. Parents are embarrassed. Their friends tease them. They feel like less of a person because they have not mastered what most consider to be this very basic skill, simple skill, most of them would think, that is essential to their daily living. And as I've kind of commented on before, many parents believe that this is a volitional thing, this is a defiant thing, which increases stress and conflict. In fact, kids with soiling and wetting disorders are at a much higher risk of physical abuse than their counterparts who do not have these conditions, at about a 3 to 4 times estimated rate. So it's important to keep in mind that these etiologies, these medical and psychological etiologies are truly intertwined. And I believe the best care that we can do offers kids a combination of therapies if they do not respond immediately to the medical intervention alone. We did a follow-up study to our quality of life study a little more recently, where we did a multi-center study with over 400 families, and the results won't surprise you. Fecal incontinence significantly decreases quality of life, and we compared this with kids who just had straight up constipation, and the differences were quite pronounced. Older children are disproportionately affected by these types of things, which should make sense because as children get older, the social ramifications become more pronounced. They don't get invited to parties. They don't participate in sports. They often have very few extracurricular activities that they do. And even in school, they may become the victims of bullying. So really what I would say is that it's crucial that we develop strategies for early identification and referral to people who specialize in this. And so I'm a big proponent of doing talks like this, and especially talking to pediatricians who tend to be our frontline folks about when to recognize the medication itself is just not working and make a referral to specialists so that we can mitigate these other problems that tend to go along with prolonged stooling problems. So let's talk a little bit about clinical management. Our individual outpatient and our group treatment take the same approach, but I just wanted to point out this paper that we did recently with some of our students that focused a little bit more on the group treatment. And you may say to yourself, really, group treatment for fecal incontinence? Yes, group treatment for fecal incontinence. And the reason for this is that it becomes a great opportunity for families to realize they're not alone. And when we do this type of an intervention, we actually split the group of kids from the group of adults and run simultaneous groups that are focusing on the same content. And in the adult group, we have a psychologist and a nurse practitioner who are doing a combined medical behavioral teaching. And in the kids group, they have a psychologist and one of our psychology externs working with the kids to teach the same material just at a developmentally targeted level. And the kids love it. They love poop group, that's what they call it. And we do activities that are kid-friendly to get them to learn. They go home with sticker charts and they compete with each other to do the best, and they get prizes and they get fiber snacks, and we all have a pretty good time there. So the psychological evaluation, whether you are in individual care or group care, is the same. Typically, are you guys having a hard time hearing my audio? All right, I'm sorry. I'll bring the computer a little closer. Is that better?
I think it fluctuates between low and normal volume. We can still hear you, but we sort of have to lean in a little bit to make sure we got the last sentence.
Okay, my apologies. You're going to get my big head screen here then. I'll lean into. All right, so for the evaluation, what I find to be best is when we are doing joint appointments that include psychology and a medical provider, because then we can do everything we need in one single visit. We get the psychological and physical exam out of the way. We can make recommendations for what type of care would be best for that particular child. Whoops. And then when we jump into treatment, generally we're asking families for a lot of record keeping because I'm a big believer, let the data drive the treatment. If we're seeing changes in stool frequency and quality that tell us we're on the right track, that helps. If it's not getting better, we need to make some adjustments so that the family feels like they're getting the help they need. There's a big educational component, behavior management skills, and the children always have a homework assignment, but we tend to make that a fun one for them. So I'll just walk through our standard treatment approach. It's a biobehavioral model. We emphasize record keeping on the part of the parents, sticker charts for the kids. In the first one, it's really just setting up a meeting with their parent where they talk every night before bed about their stooling habit and what they eat and drink. And if they take that sticker chart and fill that out and bring it back to the next session, they get to take a pick from our prize box. And that is incredibly motivating. And we make this first one really easy because we want to get our kids hooked on that treasure box because that's the motivation for when we get into a bigger ask. The next session we do is a medication module. Many parents are reluctant to give their kids medication that will help their stooling habit. And so it's really important to get families on board with the medicine. The Academy of Pediatrics has basically made a statement that once you get to the point of fecal soiling without medication, the outcomes are terrible, and that's true. So helping families to understand the role of medication and to be comfortable with their medication choices is really helpful. And then we talk a little bit at the end of that session about the 48-hour rule, which is if a child cannot or will not produce a bowel movement, we need to have them undergo an enema to empty the rectum. And this is to prevent that relapse that happens on day 3 with the stretching because of the stool burden. And we do a lot of teaching about how to give an effective enema. And if families frankly can't or won't do it, we invite them back in and we do it with a psychologist and one of our advanced practice nurses in clinic. I'm sorry, that's my dog in the background. The third session is about toilet sitting, where we teach about the appropriate posture that facilitates pelvic floor relaxation. And we teach about methods for doing relaxation breathing that will promote pelvic floor relaxation and how to do a good abdominal push. Another component that we give families is the idea of a potty box, which is a little container of toys that are kept only for toilet sitting time. And the rule is you can only play with these toys when your bottom is on the toilet. And these toys are generally things that facilitate a bowel movement. So they are things that promote relaxation breathing, like a kazoo or a slide whistle or bubbles, things that drive parents crazy, but frankly are really good for the relaxation side of things. Or they're things that promote an abdominal contraction. So those are going to be things like playing with silly putty or clay or stress toys. And those types of things actually can be quite effective for not only motivating the child to participate in the toilet sit, but also for facilitating the bowel movement. Session 4, we tend to get into some of the nutrition components, talking about the importance of hydration. Most kids, frankly, are constipated because they're just poor water drinkers. And so if you can understand the role of it and give the family strategies to improve the fluid intake, that generally will promote softer bowel movements. But like I said before, you can't switch off the medications once you start learning about hydration and fiber. This is really just intended to build good habits so that when the constipation is resolved, then we can really think about switching and using nutrition strategies as a way of maintaining good bowel habits. The 5th session is about fiber and the role that fiber plays. And the reason we put fiber after fluid is too much of a good thing is a bad thing, especially when it comes to fiber. And this is a funny thing that's changed since I started doing this work. In the beginning, kid-friendly foods really didn't have a lot of fiber in them. But now I think marketers have caught on to the fact that people like the idea of fiber in their foods. And so Fiber One bars and all brand cookies and fiber gummies have found their way into the market. And if you have too much fiber with not enough fluid, believe it or not, it's constipating. So you have to get the right ratio, and we teach families how to do that as well. And then session 6, usually by this time, kids are producing a daily bowel movement into the toilet, and the family has essentially a bowel maintenance manual from the earlier sessions. And we get into the maintenance phase of the program, which involves the caregivers taking on the primary role of maintaining the things that we've asked them to do. So in order to make sure that they do that, they have my phone number, which they can call anytime, of course, but we also schedule 30-minute follow-up visits once a month until the soiling ends and until they're really able to recognize the urge for a bowel movement. And then some families also like our help with weaning the meds at the end. So I would say the average course of treatment for these kids, even after we get through these first 6 weekly sessions, is probably about 6 to 12 months in duration to totally resolve the problem. I've already mentioned that. This is just our flyer for our poop group, which describes the problem and the sessions. Here's an example of one of our sticker charts that we would use, where we're really promoting 3 daily toilet sits after meals, because you get a biological predisposition to having a bowel movement after you eat, and has in this particular one the inclusion of some of those nutrition goals with the fluid and the fiber. And then I'll switch to the urinary incontinence, which is a shorter part of the talk, because I know I want to save some time for your questions. So again, the anatomy. The role of the urinary system is to clean your blood. And the way that this works in a very rudimentary way is that the blood is filtered through your kidneys. The water that's used to do that is excreted down the ureters and into the bladder, and then through the urethra, hopefully into the toilet. But of course, if not the case, then they wind up with someone like me. Urinary incontinence is extremely common, and it's described as a loss of bladder control. Under age 3, urinary incontinence is expected. And this has become a real problem, I think, in our culture, because we have many daycare centers and preschools that are putting a lot of pressure on parents to have their kids trained for at least urinary continence by the age of 3. And families try and get their kids started probably earlier than they should, which frequently results in toileting resistance and a longer period of urinary incontinence than might have otherwise been expected. So the diagnosis of enuresis, from a medical standpoint, that provider actually is quite helpful to me. So does the family have a history of enuresis? How often is the child urinating? Are they drinking things in the evening that might cause them to have urinary incontinence because of a full bladder while sleeping? Are they having any symptoms that might indicate that there's another medical problem going on, such as painful urination or burning sensations when they urinate? Does the urine have an unusual characteristic? Is it dark? Is it cloudy? Does it have an odd odor to it? Is constipation a problem? If you looked at that image that I had on before, you probably noticed that the bladder sits right on top of the bowel. So if your bowel is full, guess what? It's pushing on a water balloon that's likely to leak. And then the last one that I have on here is, has the child had a recent stress event or some type of trauma? And that tends to come out more so as nighttime wetting, oftentimes because the child will be dealing with those stressors in a somnolent state. The provider should do a good physical exam, and they may recommend tests to rule out infection or diabetes. After this process, then I would say it's appropriate to refer to somebody like us. I generally would not see a child until they've undergone this type of a medical workup first. There are Enuresis subtypes, daytime wetting, nighttime wetting, which is by far the most common, and primary enuresis, which occurs when a child has not achieved toilet training by an expected age, which I would say for most kids is around 4 years of age. And secondary enuresis, which occurs after a child has achieved continence, but then for some reason or another begins to have wetting. These are some of the causes of enuresis, and I'll just run through them quickly here because I know that slide might be hard to see. Anxiety, ADHD, caffeine consumption, constipation, diabetes, genetic predisposition, not enough of the antidiuretic hormone or ADH, obstructive sleep apnea, overactive bladder, slow physical development, small bladder, structural problems in the urinary tract, trouble being able to detect a full bladder while the child is asleep, UTIs, and very deep somnolence. The criteria for DSM are here, which are repeated urination in bedding or clothing, which is either voluntary or involuntary. It has to be significant, which means it's occurring at least twice a week for 3 months. And it has to be a child the age of 5 or older. The behavior really can't be due to substance ingestion that would cause frequent urination, such as a diuretic, and it can't be caused by a general medical condition. So I want to again highlight that the child is at least 5 years of age. So when we're thinking about urinary incontinence and we're thinking about school-age children, especially that daycare preschool age, that becomes a really important criteria for making this diagnosis. Unfortunately, there are negative psychological impacts due to urinary incontinence as well. Generally, there are negative social ramifications. These children don't get invited to sleepovers. They may be afraid to participate in sports or other extracurricular activities. Diurnal or daytime wetting is especially impactful on these kids' quality of life. Often it creates conflict between caregiver and child. And the other thing that seems to come up a lot is all of a sudden there are a lot of questions about, was this child neglected or abused in some way, which rarely is the cause, but it can be. So it's an important thing to evaluate. I'll go quickly through the medical and behavioral management strategies. The medical one is pretty easy. Generally, we're going to give a medication that will relax the bladder, presuming that the bladder is not fully voiding. So the most common remedy for this is DDAVP, which you may have heard of, which is essentially a method of relaxing the bladder. Now for the behavioral strategies. So there are a host of these, some good, some bad. Changing fluid intake can work. Keeping caffeine out of a child's diet should be done regardless of whether they're wetting or not. Nighttime waking on a schedule, I would not recommend. This trains the parent to wake up, not the child. Bladder training, which may involve scheduled urination and methods to teach the child to relax the bladder. Use of a moisture alarm, which has by and large the most evidence of any of these methods, and counseling if there is a stress or a traumatic event that's contributing to the wetting. There have been some interesting studies that have looked at urinary alarms versus DDAVP. And the take-home message from these is that they work about equally well with a few important caveats. Once you take a child off DDAVP, oftentimes the urinary incontinence will return. There is a higher attrition rate for the use of the urinary alarms because they wake up the whole house at night. But it's a trade-off. So usually within 2 weeks, you're seeing a significant symptom reduction in the urinary alarms, but that's a tough 2 weeks for the household, as the urinary alarm might go off multiple times in a night for those first 2 weeks. The longitudinal studies suggest that the alarm therapy is lasting, whereas the medication may not be. The other nice thing about the alarm is that it doesn't rely on a medication that a child has to ingest, which can be attractive to parents. So a couple of considerations to think about for these urinary problems. First and foremost is this truly disordered urination pattern. And so for that, you have to consider the age of the child, the developmental readiness of the child. Are they receiving social pressure from school or daycare? It's important to remember that every year a child gets older, the percentage of cases drops dramatically once they reach the age of 5. So most children will have some type of a combined medical and behavioral etiology for these problems. But again, especially with regard to the urinary problems, they generally resolve with age. So take a moment, stop, think about what you really need to do here. Is it just education and maybe some supportive counseling, or do you really need to jump in and do more behavior management? Take home points. So psychological factors in the development of elimination disorders is controversial. So talking about stress events, talking about abuse and neglect should really be considered, but are rarely the true cause of these problems. Generally, there's a medical etiology or a developmental etiology that's at play. Many cases of elimination disorder can be effectively managed with brief, targeted interdisciplinary therapies. So if you're going to do this type of work, it's good to have a medical partner and a behavioral partner working together to coordinate care and to really support the families. Children with elimination problems are at risk for other things that you should be thinking about evaluating and treating as needed. So these are comorbid behavioral problems, ADHD, which occurs in about 1/3 of cases of encopresis. So there's a very high rate of comorbidity for ADHD. Other disruptive behaviors, especially as children get older, anxiety, and poor academic and social competencies. As I've already mentioned, sexual abuse is really not very well supported as a cause for this. And in fact, there's even one study that says that children with sexual abuse had the same rate of soiling disorders as did children with no abuse. So that really suggests to me that maybe we need to rethink how abuse is viewed in this population. So evaluate the medical etiologies first. Don't assume toileting problems stem from trauma. Do be aware that these children have other psychological risk factors, and get a good care partner to do this type of work. Oh, you're too kind. Thank you. Thank you. I see that we've got about 10 minutes left, so I'd be very happy to take any questions that you guys might have.
Fantastic. I so needed this talk, Dr. Silverman. So I had two patients, well, that I supervised. Two trainees were evaluating two separate children with encopresis. And we were, telling our clinic and our colleagues until we were blue in the face, there is no trauma history. So very validating, thank you. However, I wasn't the right person to be supervising. And so my question then to you is, how do we find specialists like you to have this collaborative, coordinated care approach that really necessitates a medical provider who's very learned and also a psychologist or a mental health professional who's doing this kind of work. These were like one-off cases for me.
And they are for most folks. And I think that's really the travesty here, is that often we get people who want to help, are well-intentioned, but may not really understand what's happening for these children and for these families. There is a division of the APA, Division 54, which is the Division of Pediatric Psychology. And there's a subsection of providers that are GI-focused providers. So a good place to probably begin is to find somebody who identifies as a GI psychologist. And that person, if they don't have the specific training in this particular area, I can guarantee you they know somebody who does. And so that's generally a good place to start. The GI providers themselves often are asking me, well, who can I refer to? From around the country, I get these questions. And I wish I knew more folks because usually it's the major medical centers that will have a pediatric GI psychologist. It's a fairly specialized subgroup. So if you don't have somebody locally, then I would encourage taking a look at some of these papers that have a treatment approach. And you guys can feel free to reach out to me. I'm happy to share my treatment resources and to consult as best that I can. But I think really trying to find somebody who understands this and getting a good medical partner who works well with a mental health provider is probably the starting point.
Thank you so much for that. I just want to read some of the comments. Very interesting, very helpful. Thank you for this informative presentation. Great information presented in a clear and calming manner. Oh my goodness, yes. Very calming. I can see how beautifully you work with children. So I'm going to open this up for other people to ask questions. We have a sizable group, but I think we could handle it. If anyone wants to unmute themselves, please do so.
I have a question. Thank you so much. This has been a very helpful presentation. Could you speak to the prevalence and the difficulty of treating nocturnal enuresis that lasts into adolescence? I have a 14-year-old who has not responded to bed pads, medication, anything. And it just seems to be something that we're going to have to wait for it to stop unless you have some other ideas.
That's a concerning case, actually, because the data would suggest that by the time you get into the adolescent years, those who are going to outgrow it would have. So I would say if you're getting into the tweenie years and it's just not resolving with those traditional methods, there may be something more medical that's going on here. And I would say probably a referral to urology is a good starting point if you haven't done that already. The other thing I would double check is just to make sure that the enuresis alarm was used in the method that it's recommended. And if they have tried DDAVP, were they really adherent to the regimen? And I know that those are sort of obvious things to say, but sometimes families can be inconsistent on those application of those things because they're not always easy to follow through with, or they're not big fans of medicine. But if it seems like they did follow through with those recommendations, then I would say a referral to urology would be appropriate.
Thanks for your thoughts.
Mm-hmm. We have someone who's raised their hand. I can't see the whole participant list, so please go ahead and unmute yourself.
Don't be shy. I don't bite, especially over Zoom.
It's a 510 number with the raised hand.
Barbara, there may also be a few questions in the comments. You can feel free to ask me any of those too, if you like.
Sure. Let's see. Are you getting any questions on your end?
I can take a look. It looks like there's 6 comments here in the chat. Oh, it looks like people are sharing a few resources. That's nice to see.
Yeah.
I have a question. If no one else has a question, actually 2 questions. Well, first of all, thanks for a really great presentation. I'm a child psychiatrist. I have a patient who had a long history of encopresis and sought care through the specialty GI, Peds GI, and urology at UCSF. Is no longer having stooling incidents, but still requiring, this is like 12 months out or maybe even more, still requiring 3 enemas a week. And the family hasn't been able to wean him off of that regimen. And just any thoughts related to that. And then another follow-up question, in my experience, my limited experience, there seems to be a pretty high rate of prevalence. This patient I just talked about was in the foster care system and was adopted, and there seems to be a pretty high rate of encopresis in the foster care population. And if you could speak to that, if there's any evidence.
Yeah, and that I'll address the second question first. So when we have that type of a history of kids in the foster care system or children who are adopted, it can be really difficult to get any of the biological family history related to these types of conditions. And I think that's where having those good relationships with a urologist, gastroenterologist is important so that they can do that comprehensive medical workup. Because that one slide that I showed you with that host of contributing medical factors sometimes doesn't get fully evaluated. And it's really important to understand those things, especially in cases of foster care and adoption, because of the limited information we have about the family history. In those instances, though, that's probably another really good time to ask some of those questions about stress events, traumatic events. Were there other things there that perhaps warrant some clinical attention that could be contributing to the ongoing symptom, even if there's some symptom response to treatment, but not complete resolution. So getting to the first question, if a child is receiving 3 enemas a week, that sounds invasive, but if they're having good bowel control, it's not necessarily a bad thing, especially as kids get older and they may self-administer enemas if they recognize that they're helpful. Generally, when we have kids that are on long-term enema regimens, we'll try and wean them, not by reducing necessarily the frequency of the enemas, but the volume that we're putting into the rectal vault. And so you're starting with a full enema. In the beginning, you may try and cut that to about 75%, see how that goes for about 2 weeks, reduce that to 50% if things are going well. And sometimes that's a helpful way to really determine if they really still need those enemas. If the enemas are really beneficial and the child just really doesn't like having enemas and is looking for a method of management that isn't enemas, that might be a time where you consult with a GI about having the child undergo a cecostomy procedure, where they would actually put a surgical button into the cecum, which is the distal end of the large intestine, and they can run retrograde enemas from a pump. And this is actually a really nice procedure for people who just can't get fecal continence. Even though they have a surgical button there, they don't have to do the invasive thing of an enema every day. And they actually rinse the entire contents of the large intestine out, really preventing any fecal incontinence in most cases. But of course you would want to consult with a GI before recommending something like that. I hope that answers your question, David.
Yeah, thank you. Thank you very much. And just one follow-up, is that a reversible procedure?
It is. It is. And there is some data about the likelihood of somebody being successfully having their C2 button removed. There are a host of different types of surgical procedures that one could consider. Some are more reversible than are others. C-tube is very reversible because generally all it is removing the tube. It's like a G-tube button. But you can remove the C-tube and usually just a surgical suture, and that's it.
Thank you.
Thanks so much, Dr. Silverman. this ends our time with you, but thank you so much. And I really appreciate your offer to consult. So thank you very
Anytime.
much for that.